So sipuleucel-T, as we know, has been FDA approved with a survival benefit for many years now, and then with metastatic castration-resistant prostate cancer. You know, it's been demonstrated time and time and again in multiple studies to have very, very similar outcomes and very similar levels of survival benefit. I think the challenge that we face with sipuleucel-T is that we don't see PSA declines, we don't see improvements in time to progression, but there's an overall survival benefit. So we have to ask ourselves, how can we select patients? You know, there's not a great biomarker of response, there's not a great predictive biomarker. There's not great predictive biomarkers for most drugs that we have in prostate cancer, or one could say for all drugs that we have in prostate cancer at this point in time. That being said and done, I think there's some good kind of post hoc analysis data, we have to take that with a grain of salt, that shows that the patients that benefit the most from sipuleucel-T are probably those with lower PSAs, lower disease burden. So it totally makes sense that if you're going to give sipuleucel-T, you should give it to somebody who kind of has a lower PSA and lower disease burden, that the train is not moving too fast, okay? If you look at the survival curves, they don't split till 6 months after sipuleucel-T. So if you have somebody with really, really rapidly progressive disease, I probably wouldn't go there. But if you have somebody who, let's say, just developed mCRPC, they have, you know, 3 bone mets and their PSA is like 5 or 10 or something, that might be your ideal candidate. Of course, they have to be asymptomatic or minimally symptomatic because that's in the label. But I'm just talking about more granular detail as to who I would select for sipuleucel-T, probably be more those kind of low volume, low PSA patients and early.